Good evening, everybody, and thank you for joining us for the Hull CCG AGM 2019-2020 in, as you can see, somewhat unusual circumstances, as we normally like to meet with you all, and so we can talk to you in person and find out what your concerns, expectations are around the service that we've been providing and the future. But we're doing it differently tonight, obviously, and we're being you're joining us either by YouTube, Facebook, and we have a hashtag, which is hashtag Hull CCG. We have our normal question and answer session that's coming up later, and again we're going to be doing that slightly differently, but I'll go on to explain that. But I bid you, on behalf of everybody here at the CCG, a very warm welcome to this AGM. The AGM covers the period from March 2019 to March 2020. And complements our annual report, and we'll be providing extracts and overviews from that. I'm joined by my Interim Chief Operating Officer, Erica Daly, and our Finance Director, Emma Sainer. We'll be going through presentations following on from this, which really goes into the detail of the activities that the CCG have undertaken really between 2019 and 2020. I will be providing an overview, but obviously, although this AGM covers that period from March 2019 to April 2020. Obviously, our activities over the last 6 months have been dominated by COVID and continue to be dominated by it. So I can only really give you an update as to where we are today on the 30th of September 2020. And like some of you, like ourselves, have just watched the Prime Minister's latest address and press conference. So we sort of take each day as it comes as we go through the COVID crisis. And when we started in March 2020, we weren't sure how long it was going to last, but I think we've all come to the realization recently that we are going to have to live with this crisis for the foreseeable future, at least until a vaccine and effective treatment becomes available, is proved to be effective and is rolled out to the population. So we can all have confidence that we can go back to living our lives normally, both personally and professionally, because it really has been a challenge for us as an organisation and for you as individuals in your organisations, whether it's at home, in the family, healthcare settings or work environments, and particularly recently for students as well. It's been a very challenging time for you, and we'll touch on that as we move along. So I'll be giving the overview of what the CCG activities have been. After that, we'll be having a question and answer session, and because of the constraints of the fact that although we are here in person, we're appearing to you virtually, we can't really do our normal question time session where we're joined by David Burns, etc. Some of you will have witnessed it, but we're doing it slightly differently this evening. So we have had a wide range of questions posed to us prior to the meeting. So we'll probably cover some of them in the presentations that we're going to give, but we'll also endeavour to cover them comprehensively through answers in the second half of the evening. So hopefully those of you who have submitted questions, some or many of you will be on the call and we'll be able to answer to your satisfaction. But unfortunately, we can't offer the facility whereby we can engage in the conversation which previously has been very rich for us. And as an organisation, we welcome and value contributions from service users, members of the population, partners and provider organisations, because that's a rich part of the intelligence and information that we gather as an organisation, which then dictates some of the commissioning decisions and the services that we provide over the following 12 months or so, and help us to sort of benchmark. So, moving on, I've been the chair of the CCG now for 7 years, and I think this has been obviously the most challenging 6 months that we've had. We went into lockdown a week before the end of the financial year 2019 to 2020, so it doesn't really impact on our activities so much the previous year, but it has impacted, as I said before, as we move forward. I'm going to discuss some of how, as an organisation, we've collaborated with our other organisations. We've coordinated a lot of the activities at a local and area level. We've also tried to communicate as best we can with the public, our service users, partners and providers as well, to rise to the challenge of COVID, and at the same time be aware that things are being reorganised in a regional area as far as the NHS is concerned. So there's been many, many challenges. We've had to do this as well at a time where, like all of you in a work environment, very few of our staff have actually been in the building. That doesn't mean to say that they haven't been working extremely hard from home and various other locations, and I want to, at this point, pay tribute to all our staff for their hard work and dedication over the previous 6 months or so. We've all had to adjust to this sort of new normal, and some of our staff we've not seen for a few months, but we're in constant contact with them through video calls, telephone calls, conferences or whatever, and they've provided absolutely fantastic service to us and by extension to you over the past 6 months or so. And as we move forward, it shows very little sign that arrangements are going to change, so we're going to have to get used to this, obviously. And I'd like to extend that thank you to all the doctors, nurses, staff in care homes and other frontline staff who have really risen to a massive challenge, the biggest challenge in their professional careers and for everybody probably in the last generation. We've all had to work differently, and it's been a huge challenge. And I would like to sort of pay tribute to the way that everybody has not just worked individually, but the sense of collaboration and work together that we've seen, because many of these changes have been delivered at an operational level. We've delivered in a matter of weeks due to the imperative of having to change the service because we could no longer provide the same face-to-face service with patients and face-to-face working. We've delivered changes that we've talked about for many years, and we've delivered changes in delivery and commissioning and provision of health services. I don't know about you, but before 6 months ago, I'd never done a video meeting. I don't think I'd even done a WhatsApp call or a Skype call. The only time I'd seen myself was in the mirror when I got shaved in the morning. But like all of us, we're used to very much seeing ourselves on screen all the time now. And we have 3 or 4 video meetings per day, and I'm sure that it's exactly the same for you. And it's really the way that you can keep in touch with colleagues, friends, people that you're acquaintances, and most importantly, those people who provide the most support to you, whether those be people that you work with, because in a work environment we get a lot of psychological support from the people that we work with. But most importantly, our family, our loved ones, and the people that we care about, we've been able to harness the new technology to keep in touch with them. So what have the challenges been, really? Well, we've seen, certainly from a secondary care point of view, that's the hospital services, and I'll go on to talk about that a little bit more. Really a suspension from the end of March of normal outpatient and inpatient services. And I'll probably go on to talk about some of the numbers later, and we do have a question about it. Normal screening services were suspended, such as breast screening, screening for aortic aneurysm, also the lung health checks that we instigated in Hull at the beginning of the year. And I think Erica's going to talk about what are really valuable, important development that was for the city. As I say, we've moved into virtual technology. Consultations being delivered either by telephone, by online consultations, or by video technology. Before the pandemic, we had very few consultations that were done remotely. A small percentage, probably about 5% or so. As we moved into the peak of the pandemic, that changed to probably about 85% of consultations that were done in that way. We've moved to a system very quickly where we really had to move away from the system where people would turn up, walk into, particularly a primary care setting. So a concept called total triage was set up. And really what that means in simple terms is that if you wanted to see a healthcare professional, you had to make contact by telephone beforehand to assess the need, to assess the safety of the attendance at the practice, and what would be the most appropriate form of contact between you and a healthcare worker. And so that was something that was brought in for patient safety and for staff safety, because as we went through the pandemic, we began to realize that the virus posed risks to our colleagues, and a large number of them who tragically died and suffered severe illness through the pandemic because of the work that they were doing, and they were in particular risk factors. Many people had not really been able to take a break over the previous months as well, so people were they were working very hard, they were becoming very tired by it, and also morale was being affected. So we have to be aware of that as well as we move into another phase of the pandemic. We did an exercise where we looked at the number of changes that had been introduced across the healthcare environment, particularly in our area. And at the last count, there were 300 discrete changes that have been brought in across our area, a huge amount. So this slide, I'm going to talk briefly about primary care. As you know, we have 5 primary care networks in the city, and your practices that you'll be registered with or use regularly are part of those primary care networks. I'd like to pay tribute to them, and particularly the clinical directors of the primary care networks, for the massive innovation that they brought about at scale in primary care, general practice, because the primary care networks had only been in existence for about a year when the pandemic hit. But the massive amounts of a huge amount of work, collaboration, communication, scaling up digital ways of contacting surgeries, working together to deliver the care, the amount of development that went on was phenomenal. And I would like to pay tribute to them. From a secondary care point of view, as I said before, we're now left because of, this is a situation we're at now, because of the suspension of, as I said, inpatient elective, which means routine care, planned care, outpatients, investigations and tests, we're now left with very long waiting lists. And the Trust, Hull Royal Infirmary, Castle Hill and the other hospital providers are now striving to get back to providing the capacity that they had before, but operating in a safe way, in a safe environment that not only protects their staff, but their patients, those using the service, and also importantly prioritises those who are in most need of care. This is something which is really important, that we as a CCG are working very closely alongside them. They've moved rapidly into virtual consulting because they'd not done much of that before, and they're prioritising using online consultation, contacting patients who are on waiting lists, who are waiting their first appointment, follow-up appointment and also tests. So there's a huge exercise in contacting everybody who is on a waiting list. Similarly, in community and mental health care services, it proved very difficult to provide a lot of those services face-to-face, but we knew from the very outset that there would be a big increase in demand for mental health services, and we're seeing that as we move forward, as we move further into the pandemic and the changes that people have made into their lives. It's really producing a big toll on people's mental health, adults, young people and the elderly alike, because of the stress, social isolation, worries about illness, etc. So moving on to the next slide, which is about restoration of services. The NHS was provided with instructions via a letter at the end of July, which was based on certain assumptions about the ability of the NHS to provide services. So the idea was that the hospital would be hopefully back to normal for tests, outpatient appointment and inpatient services, hopefully by, well, on average by the beginning of December. Now, when this instruction was given at the end of July, and we were preparing for the winter demand pressures, this was before we had the recent rise in the number of cases of COVID, and also the increase in the number of hospital admissions, and tragically the increase in the number of deaths as well. So these plans are having to be modified as we speak to take into consideration the backlog that we've developed, the demands moving forward of the biggest flu vaccination program we've ever seen, plus the rise in the number of cases. So the 3 aspects of restoration: we're getting back to normal, preparing for winter, and also retaining beneficial changes delivered by it, particularly around increased support to NHS staff. And as I said before, NHS staff have all had personal risk assessments to see what the particular risks that they may face with dealing with the pandemic. But we're not out of it by any means. As you all know, it appears very clear that we're entering into a second phase of the pandemic, as was predicted over the winter period when people spend more time indoors. Other infections come forward, and obviously as an NHS we have a responsibility to deal with flu as well. So moving on to the next slide. What we call the new normal. Well, I think, as I said before, we're in a rapidly evolving situation. And I think the normal that we're going to have to deal with is living with the virus until, as I said before, we have an effective, widely distributed, accepted vaccine, which has proved to be effective, and effective treatments as well. More widespread and effective test, track and trace, which will help us see where the local outbreaks are and manage them appropriately. So it's an evolving situation. So the rapid operational changes that I've talked about were driven by safety and strong public messages around, and we're hearing those messages again, which is about protecting the NHS, following the guidance, saving lives, hands, space, face. You should be aware of all the guidance that's been given out. As I said before, screening stopped, but we're getting it back up again as we move forward. And we must continue with the day-to-day activity wherever possible of the NHS because of the time that we got behind time because of the 6-month period, because we've got such a huge backlog. Let's move on to the next slide, if I may. So what challenges did we face now? Well, as I've alluded to, the challenge that we face in Hull is we were fortunate enough in the first phase of the pandemic not to have a lot of cases. We were relatively spared. We did tragically have deaths of our patients, but we were relatively spared as compared to the rest of the country. But we went into lockdown at the same time, and we also went into protecting the NHS, whether that was in primary care or secondary care, at the same time. So there was an immediate impact on patients living in Hull who already suffer some of the worst health outcomes in the country because of the inequalities that we've talked about previously, and we'll talk again about this evening, with long waiting lists, with high incidences of heart disease, chronic bronchitis and emphysema, and particularly around lung cancer as well, and heart disease, as I said. I remember at the beginning of the pandemic, when I gave an interview about it, saying that despite the pandemic, we will still see lots of people in Hull suffering severe ill health and premature, unfortunate death because of the pre-existing health conditions that we have to tackle in the city through improved lifestyle, through initiatives about smoking and exercise, and all those things that we'll go on to talk about. Because if in Hull you had a lower chance of catching the virus, but because of these underlying health issues, we had a very vulnerable population. And because of that, there would be the risk of COVID-19 creating greater inequalities than we already had. So I did an exercise just really for my own interest, which was to look at what the population of Hull had died from in April 2019 compared to April 2020. And what came across to me was still the very large numbers of our population that were suffering these chronic illnesses resulting in their premature death, such as heart disease, lung cancer, pneumonia, chronic lung disease. Even in April, when we were seeing the beginnings of the rise in COVID-related deaths in Hull, we mustn't forget the underlying health inequalities, the health disadvantages that the people of our city have. And that's where the Hull CCG sort of redoubles its efforts, not just to deal with the COVID challenges, but to deal with the underlying challenges that our population has. So that's the two aspects of it, the work that we do generally as an organisation and an overview of where the health service has been and moved on to in the last 6 months or so. And this is my final slide. As I remember when the pandemic we started to feel it at the end of March, and the first thing that a lot of people did was to go out and stock up on toilet roll. And I remember thinking at the time, this is so much more about this. We didn't know at the time what was going to happen at the beginning of March. We had no idea how long it was going to last, how it was going to affect our lives, how it was going to affect the delivery of the health care that we all take for granted and that we hope will be delivered to us. As an organisation, we've responded to it. As a population, you have responded to it, and all our healthcare providers and partners have responded to it. We are not yet, we can't really see the end of it just yet. So it is about redoubling our efforts to look after ourselves, look after our colleagues, look after the people that we live with by observing the rules and being sensible and above all else, trying to look after our underlying health, because that is the most important thing. Thank you. I'm going to hand over to Erica now for the second part, after I've cleansed the clicker.
Thank you, Dan.
There you go.
Thank you. Thank you. Good evening, everybody. I've got an opportunity to share some of the work we were doing last year, to give you some examples of some of the work that we started, but equally how some of those examples have really responded to the crisis and the issues that Dan outlined. So I'd like to start by just explaining a little bit about the CCG. Some of you may be more familiar with clinical commissioning groups than others. We, as the CCG, a statutory body, we receive the funds for Hull to spend on healthcare from central government, and it's our role to make sure that that money is spent well, that we work with our providers of health and care services, and we spend that money to get the best outcomes for the people in the city. And last year, along with the usual obligations around delivering those statutory duties, we were issued with what was called the NHS Long-Term Plan. It was published in 2019, January 2019. And it set out some very specific priorities and aims for clinical commissioning groups and providers of healthcare and social care services to determine how we should set the scene for the coming years as our health needs change and demands on healthcare change, how we work together to make sure that we've got health services and care services that are fit for the future. And in Hull, we embarked on several initiatives to get that plan underway. A lot of that was fitted really well with the work that we do in Hull, as Dan has described. We are a city with very complex needs, high levels of deprivation, and people with multiple conditions and wider determinants of health that impact on their daily health and well-being. So we were really successful in that we were chosen as a pilot site, one of only 10 in the country, to run the targeted lung health checks for people in our city who smoked or had smoked within particular age groups, where they could access screening, scans if necessary, and advice about health and well-being and about staying healthy and getting the right support for their respiratory health if required. And we started those health checks last year, and we got off to a really good start, and over 500 people were screened in the first 2 weeks. And you can see there on the picture some members of the fantastic team who started working on that programme of work. We did have to stand it down during COVID, but that screening will start again in the west of the city in October, and then starting the rollout across the remaining parts of the city from January next year. Will have to be delivered a little bit differently in line with the COVID restrictions, but we're really pleased to get that back up and running. The long-term plan highlights how it's really important to get care early, to get screened early. It's about anticipating what needs you may have and preventing ill health. And so some of the examples that I've got to share with you this evening, along with the lung health check examples, are really demonstrate the really good work that's been done in Hull over the past 12 months. The long-term plan also set out some structural changes for us and how we work. Dan's talked about the 5 primary care networks in Hull who concentrating and focusing very much on the population health needs in the areas that they work. And we are also part, as a CCG, along with 6 other CCGs, within the Humber Coast and Vale Integrated Care System. That received formal status as well in the recent months. I'll move on to the next slide, which explains a little bit about the Humber Partnership. This partnership was established recently, and we sit as a CCG within the Humber Partnership. You can see on the slide there the other providers, local authorities, health and care providers who work together as the Humber Partnership to make sure that wherever possible we're doing things once. So where it makes sense for us as a CCG to look at some of the bigger services that are provided across the patch, that we're not duplicating, that we're making sure that there's integration with the right providers, with the right partners, but they're coming together and having the conversation about actually how can we integrate this better. Patients tell us, and the long-term plan directs us, that we need to coordinate better, we need to integrate our services better, and that access and care coordination and point of contact for patients should be streamlined and made as simple as possible. So working at a level across the Humber with this wider group of partners actually enhances that conversation and gives us a much broader opportunity to do that work. It doesn't take away from the work that we do in Hull, and Hull CCG is still very much focused on what our city needs, but there's learning from other people to be had from some of the work that we do, and equally we can learn from others. So I wanted to focus particularly on some of the work that we've done around supporting vulnerable people. So that's a little bit of a theme for this presentation. And some of you will be very familiar with the fabulous Jean Bishop Integrated Care Centre and the work that they are now into their third year actually of delivering, which fits really well with what the long-term plan was telling us to do. So that's identifying our frail elderly population, identifying people who would really benefit from having anticipatory care, having coordinated care delivered by a team of people in one place, and that care then being coordinated and carried on in their own home. When we set up this service, we were very much working with what people had told us in Hull is that they don't want to go into hospital. If their care can be coordinated and delivered in their own home, then that's the care that they want. And the Jean Bishop Integrated Care Centre has been doing a sterling job in delivering that. It's a multidisciplinary team of people, community geriatricians, physios, social care services and the voluntary sector all working together. But the short film that I'm going to show you in a moment actually demonstrates how they had to respond and enhance that service and really turn it around in terms of how they were going to continue to support that population of people in Hull during the pandemic. And an essential part of that was the work that they did for care homes. I'll just hand over to the film now, and Dan Harmon is going to tell us a little bit more about it.
So the Jean Bishop Centre was set up to deliver proactive care for frail residents of Hull, delivered by a specialist multidisciplinary team involving doctors, nurses, therapists, social care staff, really to get the best outcomes for the residents of Hull. We set up the advice and guidance line in response to the COVID-19 pandemic. We had a very short window of opportunity to try and get basically the care right across the system for frail residents of East Riding and Hull. And we really felt we were best placed to do this as we're a specialist frailty service. So we felt it was important that we led on this important piece of work. And we worked alongside both CCGs, clinical leads across the patch, care home staff and care homes leaders, really to try and deliver care for frail residents of Hull and East Riding at a really difficult time. The real challenge was we were aware that the cohort of patients, the group of patients we look after, were particularly vulnerable to the effects of COVID. We were faced with anticipated high infection levels, and unfortunately a number of our residents would actually pass away with the illness. So we really felt that we needed to work collaboratively across the patch to get the care right.
From the carers' perspective, we offered lots of support to various care homes that had outbreaks that were having to deal with kind of unprecedented levels of illness and deaths. And so it was that specialist team being able to support them as well, and working with local authorities and public health teams. From a patient perspective, the people looking after them were able to get specialist advice rapidly, 7 days a week. They were able to be supported to be cared for where they wanted to be cared for, so that could have been in their own home, in care home, or in community rehabilitation beds. And so we were able to support people to have quality care for COVID-related things and non-COVID, where they wanted to be.
There was very limited national and international guidance on how to treat COVID-19, and that was constantly changing. And we found ourselves in a situation where we were reading evidence and trying to change clinical pathways almost on a day-by-day or week-by-week basis, which was a great challenge. But I think one of the successes has been the way in which, as a system, we've approached that, and it's been a privilege really to be involved in that.
Thank you. A really good example there of how the team responded. They are back now working to providing the normal service alongside continuing an element of the rapid response and continuing to support our care homes. Another really good example and another one that demonstrates the real benefits of multidisciplinary teams being based together in one area and focusing their efforts on one particular group was the work that we started last year to commission a new health service that was specific for people who are homeless. And we originally commissioned this around people who were being discharged from hospital, making sure that when they were discharged their health needs were attended to and that they were put in touch with the right services. And again, this team were able to respond in a fabulous way to ensure that during the COVID period they could continue to meet the needs of that particular group, but even go further beyond in terms of what they were able to offer. And this particular project, which Dr. Lucy Chiddick led, and I'm going to play the film, and Lucy will explain a little bit more in a moment, was recognised as good practice by NHS England.
The homeless in the city are one of the most vulnerable and marginalised group in our city. Their health needs are vast and complex. They have a high level of morbidity, which means they have a huge number of complex health needs, from physical health needs to mental health needs. As a response to the pandemic, Hull City Council brought in all the rough sleepers and homeless people in the city into temporary alternative accommodation. We looked at their substance misuse needs, their mental health care needs, their housing needs, their adult social care needs and their health needs. And collaboratively, with lots of different agency involvement, we were able to mount a really strong response to the needs of this population.
We build up a relationship with the people that are here. We signpost them through to the services that they need. A lot of the people have been street homeless for quite a long time, so they could be completely disengaged from services.
I deliver immediate support for anyone here with drug or alcohol support needs or relapse prevention.
We're here for the security of the residents, the security of the property, the council staff, the nursing staff, the owner, you name it, we're here for the security of it. However, it goes beyond the realms of security, because when you're sat here behind a desk and you see people coming and going day in, day out, you get a rapport with them, you get a friendship with them, and it becomes more than security, you care.
The Nhs site's fantastic, it's beautiful, the gardens are beautiful, there's trees, there's grass, greens everywhere. The buildings are very nice, the rooms are very nice. It's so nice that it has to have a positive effect on people, and that's what I've noticed.
We worked with Hull City Council to get a space in the Ainsley building, really, where everybody's come together from health and housing, meme, all the different services. Everybody focuses on what that person needs, and I think that's why it works, because it's not about trying to make a person fit a service. We've started from scratch with this service and we've been able to make it fit the needs of our people.
There's one guy in particular who we work with who is now part of our cohort, part of the meme cohort. Since he's been here, he's refrained from drug use, he's taken his medication regularly, he's starting to see his children again, engaging with his family, and I think the fact that everything that he needs is on site here makes it so much easier for people who are really, really chaotic to have those services basically at their door.
I started doing my drug tests, which I've been negative for, and all my tests, and that's all done in-house. Before, I didn't have nowhere to turn or nowhere to go to, but here, you can literally just come downstairs and sort of say, look, I'm having a bad day, or can I chat to someone, or can I see the nurse about something. It's just amazing how it works here. The staff have been amazing with me, and I don't know where I'd do without them all, to be honest.
So this centre really provides that safe place from which people can take a step back and look at their other needs. This way of working, this way of accommodating people, collaborating together to support the most complex individuals and complex needs in our city. We cannot lose what we have, and we are all passionate and committed to ensuring that this can continue.
Some really great examples there, and I think it sets the benchmark for how we want to commission and organise our health and care services going forward. They demonstrate how it's so much better when it's delivered together, when teams work together and that care is organised around complex individuals rather than expecting people to fit into services. And that takes me on to my final slide, which is really just to highlight that as a CCG, we do look much more wider than just health and care. We work with our public sector partners from the police, fire service, ambulance service, local authority and voluntary sector with on the whole health and care place plan. One of our projects which took place last year and which we're now rolling out across the city was working together on what we call the Beverly Road project. This was essentially focusing our information and pulling that together and looking at the demands on each of our services and how we could use that information then to inform us about how best to work with communities and put the right services in the right place. Sharing that data really taught us a lot in terms of how it's much better to have that broader partnership and to get into the communities and understand what really works for them rather than us dictating actually this is what we think you need. We're working with communities to make sure that the services are fit for purpose and really improve their outcomes. So the Beverly Road project will be expanded across the rest of the city. We're also at the place board looking at community wealth building. It's a new term, but something that we discussed in detail at the last meeting, and it's really about, as commissioners and as providers of healthcare and social care and voluntary sector services, we spend a lot of money in the city, but it's that conversation between those broader partners about are we spending it well and are we investing it back in Hull. So we have a part to play in that local economic development as commissioners and as providers of care. Part of that work will really look to enhance our amazing voluntary sector partners who really responded so well during the COVID pandemic. We always knew that we had a real wealth of voluntary and community sector partners across Hull, but it really highlighted how important they are and how we really need to make sure that they are central to some of the work that we're doing. And there's almost a default position in terms of whether that community and voluntary sector provision can be integrated into some of the other services that we design and develop. Health and care transformation is always at the centre of all our plans. We work closely with the local authority, and that's about integrating care, making sure that health and care, for the person in receipt of that, it doesn't matter where it's coming from. They know their needs are getting met, and we do the work behind the scenes to make sure that that's a seamless provision. And finally, we did set out last year really learning from some of the co-production and communication and engagement work that we did with children and young families around continuing to focus on improving our services. There were certainly areas for improvement in terms of access to some of our mental health services for children, some of the diagnostic services. That work has continued, and we continue to keep that at the centre of our plans going forward. Okay, thank you. I'm going to hand over now to Emma Sainer, who is our Chief Finance Officer, and Emma's going to talk us through the financial performance for 2019-20.
I am.
Thank you, Emma.
Thanks, Erica. That's great. Good evening, everybody. Yes, I am the Chief Finance Officer here at Hull CCG and have been in post since its inception, and incredibly proud to be in this role and have the great pleasure of taking you through the statutory part of the annual general meeting. It is a statutory responsibility that the Clinical Commissioning Group lives within the resources that it's allocated to, and therefore this part of the annual general meeting, while some might find it quite boring, I think it's the most exciting, and I have the pleasure of taking you through some of the numbers, where our resources are deployed across the different services that we have responsibility for buying on behalf of our population. I'm going to take the opportunity to give some reflections on what matters to me in this role, and how we provide, I think, a crucial sort of enabling function to a lot of what Dan and Erica have described this evening already. And then I'm finally going to just look at to the future, because I think the landscape within the NHS and how health and care is delivered is changing. As Erica's described, as part of the Health and Care Partnership within the Humber, there are a lot of organisations, and I think you get, again, reflections on what and how that might work going forward, hopefully will be helpful to you. So, in terms of the financial targets, the 7th year running, we have lived within our financial envelope, so we have broken even against the allocation that we're set. Our total expenditure is just over 480 million, so a significant amount of resource that we deploy for the benefit of the whole population. I'm also particularly proud of the fact that we've lived within our running cost allocation, so that we're set nationally a target to live within for the running of the CCG, and again making sure we do that as efficiently as effectively to preserve as much of our resources for frontline services is absolutely vital, and therefore this is a huge indication of that. Those of you who've heard me speak here before and everywhere that I get the opportunity, paying our bills is a hugely important priority for us, particularly non-NHS providers. I think as a public sector organisation, ensuring that we flow cash into quite often small non-NHS parts of the country is really important, and never more so in the period that we've just been through. In terms of audit, we are externally audited by Mazars, our external auditors, and really pleased to say that for the 7th year running we've been given a clean bill of health. That's both for in terms of how we've discharged our responsibilities and the resources that are within our control, but also around value for money. It is a hugely important part of my responsibility to ensure that we do that in an effective, efficient and economic way. I have to say, financial performance, we as accountants aren't the ones that spend the money, so a huge thank you to our providers, partner organisations and the CCG wider team who are responsible ultimately for delivering this performance. In terms of where we spend our money then, so in usual form, I've gone through a little bit of the numbers. We love our numbers. And I was just going to draw out a few sort of key highlights. Unsurprisingly, and as you would expect, the vast majority of our resources are deployed within the hospital setting. Predominantly that's Hull University Teaching Hospitals NHS Trust for Hull CCG, because the vast majority of our patients access hospital services through that route. You will see some variation. I think the slides are going to be made available, and so we'll just explain some of the movements between the different years, and particularly where I'm happy with them and where there's improvements to be made. You will see that our investment in community services, mental health services and primary care is increasing. It looks like there's a really big jump in primary care from 17-18 through to 18-19. That's because we obtain delegated authority for commissioning of primary care. So it's not that we just suddenly decided to spend sort of another nearly 50 million on primary care. We did get additional allocation, and you can see that running through the bottom line with our resources going up sort of equal and opposite to those levels. I do think that we have a responsibility to ensure that, particularly for those services, that they increase as we move forward. On the next slide, you can see that whilst in absolute terms that there are increases within community services and the out-of-hospital environment, the overall percentage is coming down, and in terms of our percentage of resource that is being deployed in those areas. The reason I say that I think we need to continue to invest disproportionately and more heavily in the out-of-hospital side of our business is because of some of the challenges that Erica and Dan have described, particularly around long-term conditions. We have a very, very large number of our population who do have significant long-term conditions that actually, you know, for them are much better, their care is much better delivered in an out-of-hospital setting. Those of us who've got relatives and family members with long-term conditions are well aware of the fact that actually having treatment in your own home or as close to your own home for those types of conditions is absolutely the optimum, and hence why we are working incredibly hard to ensure that we stabilise investment across the responsibilities that we undertake. I forgot to mention on the last slide, but I'm also very proud. I think I can go back. Yeah, I can go back. Technology is brilliant. So in terms of running costs, you can see there we are on a downward trajectory. Now, NHS England have set us a target to reduce our running costs, and in numerical terms, you can see that happening. So in terms of what matters to me, as I've hopefully sort of described already, one of our key responsibilities is making sure that we have an eye to where our resources are deployed. There's a huge amount of fragmentation still within the NHS, and when you look at the work that we do with our local authority, and I do think that moving forward we have a responsibility for ensuring that where our services are being delivered, that they're being done in a sustainable and stable way as we possibly can. One of the things that we've been incredibly proud of, I've personally been incredibly proud of over the last few years, is our work with Hull City Council. We have an integrated financial planning operation that means that we are in a very real sense looking at the totality of resource that we've got across health and care and thinking about how we prioritise that. I also am incredibly proud of the fact that we are renowned for looking beyond just our organisational responsibilities. You know, we accept the wider determinants of health often are the things that improve people's health and well-being, and we look at actively wherever we can, as you've heard from my two colleagues this evening, at actively investing in those services. We are part of a wider integrated care partnership, and that may come across a little bit sort of management speak, but that is about, wherever we can, reducing the impact of delivery of care across organisational boundaries. We passionately believe that in the services that we buy on your behalf, that there should be no sense of organisational boundary wherever that's possible. And in terms of the look to the future, then, this is my sort of final slide. I think the work that we've done and what you've heard through the pandemic in particular has given us a huge amount of learning. In the world of finance, I have to say the levels of efficiency that we have seen where our frontline staff, our colleagues, are genuinely just getting on and doing the right thing, regardless of what whose organisation badge they have on their body, has meant that they, in effect, we are using our resources much more effectively. And I think, what you've heard from my colleagues is capturing that, harnessing it, and making sure that it's in place for the future. I do feel, I'm not just saying it because I'm the finance person, I think the role of finance in the future is absolutely fascinating and crucial. I think we are a fundamental part of enabling a lot of this change. It isn't all about counting and scrutinising the numbers. What it is about doing is freeing up and enabling resources that genuinely and demonstrably make a difference to our population, and I feel incredibly passionately about that. There's a huge amount of challenge facing us. We've got, we're looking at restoring services, within COVID secure regulations. That does come with additional cost. It has an effect on productivity, and there's no getting away from that. However, we have an awful lot of resource at our, at our fingertips, and I think there's a genuine opportunity to do better with that, working together over the coming months and years. And that's why, people who know me, I'm always excited, and that's why I'm particularly excited. I have the great pleasure of leading us into a video clip of the highlights of the year, but also a look back at Hull 2020. Thank you very much.
My colleague Colleen, and Colleen supports me going to talk to GPs about reasonable adjustments for people with a learning disability. When you went to your doctors, you took your health checkbook, didn't you? Yeah. And what have they booked you in for?
For exam.
So they've booked you in for your flu injection.
team in Hull has come together, really thought about what are some of the issues that they need to solve and how they can make the Lung Health Check become a reality.
This team works so hard, day in, day out, to serve the most severely frail and vulnerable people in our city.
Good evening, everybody, and thank you to everybody who's joining us via Facebook and YouTube and on the phone today. Thank you to our panel members for their presentations. I think it's given us an overview of an extraordinary and kind of challenging year. And I suppose, like me, you'll be thinking that all seems like a lifetime ago. And I just want to take a moment just to really thank the CCG for the work they've done in supporting the city through this really challenging time and for their role within the pandemic response within Hull. So this is the bit where normally you get the opportunity to sit in a room and ask some challenging questions around your thoughts and questions around healthcare services in Hull. Due to the fact that we're doing this online, we won't be able to do that the way that we normally do, but you have submitted some questions to us online, and I'll be asking those questions to our panel members on your behalf. And I will go through the questions. There'll be some responses. If you do have any follow-up questions, we won't have the opportunity to take those live today. But if you want to submit them via YouTube and via Facebook, we will endeavour to come back with responses to the questions, which we will publish online on the website. So, the first question we have is from Sophie Allen. And Sophie's question is, Hull has one of the highest rates for this in the country, and this is around smoking. And in the current pandemic, this is especially not healthy for both the smoker and those who are inhaling second-hand smoke. What are the CCG's plans for reducing smoking in Hull? And Dan, can I pass that one to you?
Yeah, thank you, Jason. And thank you for the question, Sophie. And I think I referenced in my presentation that when I looked at the list of causes of death for people in Hull in those 2 particular months, what struck me when you actually see a list of people who have died from lung cancer, you get a feeling of the toll that the disease brings on the people of Hull. And it does, again, it's not one of those diseases that is, it does discriminate, and it discriminates in Hull. It obviously discriminates between smokers and non-smokers, but it also discriminates within the populations in Hull. 80 out of 1,000 smokers will die of lung cancer, and smoking will probably kill up to 1 in 2 of people who do smoke. So these are normal public health messages that everybody knows, but it is important to sort of reiterate the importance of stopping smoking and stopping people starting smoking. So Hull CCG works very closely with the Hull City Council on Smoke Free Hull, which is it's a collaboration between ourselves, local authority, and the Hull Alliance on Tobacco Control. And also, we signed to make Hull have a smoke-free generation. We signed that pledge a couple of years ago. And we have reduced smoking rates in the city. 5 years ago, more than 45% of adults in our most disadvantaged areas smoked. This has decreased to 35% through targeted support. But it's not enough. We need to do more of that. And interestingly, that 35% of smokers in our 35% of adults in our most disadvantaged areas, that compares to 13% in our least disadvantaged areas. So there is a big difference across the spectrum. So we need to concentrate our efforts in those populations that have the highest smoking rates and those whose health can be most seriously affected by it. 92% of our children and young people choose not to smoke. And the number of Hull women smoking in pregnancy has decreased significantly in the city. So smoking rates have gone down nationally. They've gone down in Hull, but they haven't gone down in Hull as much as they have from a national point of view. So what are we doing about it? Well, Smoke Free Hull, which is a service jointly commissioned, well, the local authority has primary responsibility for commissioning stopping smoking services, provides expert one-on-one support for smokers, free stopping smoking aids, such as nicotine patches, gum or Champix, someone from the service to encourage people, which is one of the most important things that we need to do to keep people motivated to do it. And we'll also support individuals who have started or wish to start their quit process by purchasing e-cigarettes. Now, the other thing that it's important to say is that another area that we're looking at, as a port city, illegal and illicit tobacco smoking is a significant issue because it not only has a direct impact on the health of individuals, but also provides significant financial support to organised crime, which has an impact on people both locally, nationally and overseas. Because as you probably know, the average price of a packet of cigarettes now is over £12 for 20. So that is a significant amount of money for people. So I think that what's happening is, and one of our concerns has always been, the purchase of cheap illicit cigarettes. So that's something that the Hull Alliance on Tobacco Control are actively trying to target, with some success actually. So I hope that's given you an indication of the seriousness with which they take the issue and some of the work that we do working with partners to try and impact on it. Thank you, Sophie.
Thanks, Dan. And Sophie, thank you for your question. So the second question we have, so this is close to my heart, this one. So this is from Beverly Wyan from Hull CVS. So a small project funded by the CCG had a particular focus on addressing, albeit at a low level, the mental health needs of children and how they coped as life, family situations and schooling during lockdown. So a hugely concerning period for everybody. Does the CCG plan to provide any further support through the curriculum or financially supporting projects to help enable schools, colleges and further education to work with children and families on the mental health needs arising from the lockdown? Erica, can I pass that to you?
Yes, thank you, Jason, and thank you for the question, Beverly. We did commission several small projects last year with a view to understanding better how we can commission longer term to meet the needs of young people with mental health problems. One of the areas that we really want to understand better and create a greater focus on is understanding why young people might not access services when they need it. So we've just commissioned a small piece of research with Hull University to actually start some of that work. So making sure that we understand why young people might not access early intervention and prevention services if they feel that there's some stigma associated with that, and then we can design the services accordingly and make sure that young people are using preventative services and getting early intervention when they need them. So we do have some good examples. It's another area where we can't do this on our own, where we really need to work and engage with the young people, work with schools and colleges, work with the school councils. We've got various mechanisms in terms of trying to make that engagement easier through online Instagram campaigns. We have a commissioner campaign called Got Your Back that's actually directed and delivered by young people, which puts out the messages that encourage people, and also is another way that we can engage with people and get young people to provide us with some of the information that we need to make sure that we're designing services in the right way. So a little bit of a long answer to, but yes, we absolutely do continue to provide that further support. We will be continuing with those pilots. We'll be looking at the learning for them, and lockdown has certainly heightened some of those issues for young people, and whilst during lockdown we saw a reduction in some of the referrals to our campaign, exam services. I don't think that's necessarily a reflection of some of the issues that children and young people are facing. So we are working with across the voluntary sector and with our more specialist providers to look at how we need to respond to those needs.
Thank you, Erica, and thank you, Beverly, for your question. So moving on, the next one, this is from Alan Bowmaster. And Alan is saying, and I think this is a conversation I've heard in a number of places over the past few weeks, during lockdown I've been speaking to a number of older and vulnerable people who are really concerned. When is routine non-emergency surgery going to start again? Dan?
Thank you, Alan. I do appreciate that this has been a great anxiety to patients, not only in the city but throughout the wider area that use the hospitals in our region. And it's something that at the CCG, latterly over the past few weeks, since the end of July when the instructions went out to try and restore services back to normal, we've been spending a huge amount of time on. But I think it's important to rewind in a way to say the beginning of April, when hospitals were told to make as much capacity available as possible for the possible influx of patients seriously ill with COVID that would require emergency admissions, intensive care beds, and so lots and lots of what we call capacity, which are the number of beds, staff and services in the hospital, were redirected to provide that service. So because of that, thousands of outpatient appointments and routine surgery was postponed because of that, cancelled, postponed. At the same time, as I'm sure you're aware, Alan, people stopped presenting into the health service, partly because of fears of catching the virus and also because of a desire to protect the NHS, which was obviously part of the very clear messaging. So what happened was, because of that, referrals into the hospital from general practitioners for outpatient appointments and surgeries and other investigations reduced by at least 55%. So that has resulted in thousands of patients who have yet to appear in the system to have their situation assessed, listed and decide whether they actually need surgery. So there's a huge backlog, not only of those patients who had their treatment interrupted, but also for those who never came forward to have their treatment started in the first place. So the numbers are large, and the hospital has been given a time frame by which it needs to get back to the state it was in January 2020 before the COVID well, so there was a situation in January 2020 and the hospital have been instructed to try and get back to that position by the end of March next year. And the way they're doing that is by prioritising everybody on a waiting list, whether it's for outpatient appointment or for surgery. And that prioritisation is being done by senior consultants and medical staff at the hospital. And so everybody who was listed for surgery or had surgery planned is prioritised, and it's a sort of range from 1 to 4. 4 is deemed to be routine, 1 life-threatening. So as you can see, there's a range. So because, and 63% of patients waiting for surgery are deemed to be level 4, so that's non-emergency surgery. So there is this prioritisation process going on. Previously, patients were sort of prioritised by how long they've been waiting on the waiting list. But now it's to do with the seriousness of their condition. And so we've got patients who we know have got urgent treatment that's required, priority treatment required, and at the same time are unknown to the system, are being referred in, and we're finding out what their priorities are. So when we talk about routine surgery, I think actually, will we ever get back to the situation where we call it the same thing? Patients' clinical needs for surgery will be assessed in a different way because of the pressures that are in the system and continue to be in the system. But what the hospital have said is that within the next 24 months, they will endeavour to treat everybody who's on a waiting list. But that will mean, given the situation that we're in now, and we don't know what's going to happen over the next couple of months or so, there will be patients who will be waiting much longer for their non-emergency surgery than they would have been previously. That is despite the best efforts of their GPs, there are hospital specialists, nurses, managers at the hospital, because we can't operate on the same number of people in the same time because of increased hygiene measures in operating theatres, use of PPE on and off, and reduced capacity within the system. Unfortunately, that's the reality. But I can reassure you that your care or your friends, colleagues, neighbours or whatever is being looked at and is being prioritised. You have not been forgotten by the Trust.
Thanks, Dan, and thanks, Alan, for such a timely question that I'm sure is on lots of people's minds right now. If we move on to the next question. This is from Terence Sullivan from the HU4 Community Network. So it's quite a long one. So it is well known and recognised that huge gaps in health and wellbeing services are apparent within HU4, which is a particular geographic area of Hull. And the question is, why has the NHS sold off land from Pickering Ward and not reinvested the monies in areas of the ward, leaving a gap in services and the health and wellbeing of many, many residents ignored? What does it take for the CCG to invest in areas of HU4 so that residents have the same health and wellbeing services as other parts of the city? So, Erica.
Thank you, Jason, and thank you, Terence. Yeah, we absolutely acknowledge the lack of a health facility directly within the Boothry estate area of the Pickering ward. There are obviously GP practices within the wider HU4 postcode delivering services to patients in the city, but we acknowledge that there isn't anything specifically in the area that you're referencing. In terms of the question around how we invest or sell, reinvest property, we actually can't do that because we don't own any buildings, so the CCG can't sell off and receive monies from the sale of such. However, we do have a new development in the west of the city, the West Hull Hub on Calvert Lane, and that will provide expanded health services in the HU4 area. So it will offer an opportunity for communities and wider groups to get involved and deliver services from that new site. There'll be over 32 clinical rooms, and the building is we only just had the business case approved, but I understand the building works have started on that building. So we want to continue working with you and working with residents in the HU4 area. We would do this alongside the council. So we absolutely want to make sure that we are developing community-based services and facilities wherever appropriate. So we continue to work with you and keen to do so in the future, Terence.
Thanks, Erica, and thank you, Terence. So the next question, these are two questions which are around primary care and GPs. So the first one's from Tori Bryan, who says, once COVID measures cease and life gets back to normal, will GPs continue to primarily do telephone and virtual appointments, or will they just return to their standard appointment procedures? And the second question from Alan Bowmaster again is, if GPs are seeing fewer people face-to-face, then why does it take much longer to get a reply over the phone? So, primary care, Dan?
Thank you. Thank you, Tori and Alan. There's a lot in these questions, and it gives me an opportunity, thankfully, and I thank you for that, for explaining some of the changes that have happened in general practice and will continue, really, as we move forward. But I do understand that these are anxieties that a lot of patients have had because they're communicated to us. There are also anxieties that general practice has about the services that they're continuing to deliver, and would be happy for us to have the opportunity to explain to you sort of what's been happening and what might happen. I'd really prefer to have done it if we were all in the same room together, but that is not the case. So we are actually having to do our annual general meeting virtually, which is completely different to what it would have been before. So when the pandemic struck at the end of March, the beginning of April, what general practice had to do was it had to very, very quickly change the way that it provided its service, from basically a face-to-face provided service to one that was done remotely. And that was, as I mentioned before, due to the worries about communication of the disease, patient safety, staff safety, other people coming into the surgery being exposed. So practices within their primary care networks, and it was really great actually that we'd established, or the 5 primary care networks has established themselves, because it was really demonstrated the benefit of what we call general practice at scale, where you've got larger practices where you can introduce changes quickly. So practices had to introduce hot and cold sites where patients could be seen where they had symptoms that could be COVID related. And so there we would have to have full PPE, we'd have to have social distancing, we'd have to have enhanced hygiene and disinfectant and infection control. So the number of patients that could be seen was very small, and also on home visits as well. Whereas in the cold clinic, that would be where things could be seen that weren't COVID related. And other things were suspended, like cervical screening, immunisation, so some other services. But general practices continued to be busy. And what happened was some of the changes that we wanted to introduce over a long period of time, or had begun to develop over a long period of time, happened very quickly. We were always doing telephone consultations. Some people were e-consulting via email, and we were having some virtual appointments. But we had to move towards it very, very quickly, because we had a situation where we needed to know what was wrong with the patient, really, in terms of either COVID or non-COVID, so it was safe for them to come in, or what service would be best for them to access if they needed to come in, or if they could access it outside the practice. So these changes happened very, very quickly. But at the same time, a lot less people were coming forward. So the actual, what we call footfall, the number of people coming into practices, reduced markedly, which gave the opportunity for these changes to come into place. And practices, due to their best efforts, cooperation of the patients, and also the joint endeavour about keeping everybody safe, made that possible. So I think virtual consultations, telephone consultations, appointment will continue in the future. We went from maybe 5% up to 85%. It's settling back down. We don't know what the optimum is, the best is, because we know that some things have to be done face-to-face and some things don't need to be done face-to-face, and it's settling down. Practices are continuing to offer face-to-face consultations, but it isn't the standard appointment procedure at the present time. It is available, but after discussion with the GP as to what is the best type of appointment for you. And for some people, it's much more convenient for them to either have email or telephone or to use the internet. So we've introduced a range of appointments, none of which will be standard in the future. Moving on to Alan's question, if GPs are seeing fewer patients face-to-face, then why does it take much longer to get reply over the phone? Well, they may be seeing fewer people face-to-face, Alan, but since the edict went out that the NHS was getting back to normal, it was fully open for business and people should come back again, coupled with the fact that people hadn't been coming forward and had conditions they weren't treating, and also issues to do with the hospital, demand in primary care now is probably higher than it's been for years. So they may be seeing fewer people face-to-face, but I can assure you the contacts into primary care, whether it's telephone, requests for prescriptions, letters, advice, appointments, is higher than ever. So that is why what determines how long it takes you to get a response depends on the overall demand in general practice. And it is very, very high at the moment. GPs are working extremely hard to provide care to people who haven't come forward, the normal care that they provide, and also gearing up for the flu season and all the things that they haven't been doing, such as vaccinations and immunisations, cervical screening, the chronic disease management. And the other point I would make is that a telephone consultation probably takes longer than a face-to-face consultation, and a video consultation takes even longer. So these things weren't done to save time, they were done for the virtue of patient safety. So I hope that's gone to some means of trying to explain to you that it's actually to do with a larger number of people coming into primary care rather than fewer people coming in.
Thanks, Dan, and thank you to Tori and to Alan for those questions around primary care. So moving on to the next question. I think we've already kind of touched on in the earlier presentations around the impact of COVID and the impact on particular communities. So I'm really grateful that we have a question here which is around health inequalities and our BAME communities. So thank you to Francis, my friend Francis from Hannah. So Francis says, at the peak of COVID-19, members of BAME communities struggled to get appointments or follow the various information being circulated for the simple reason that most did not speak or understand a lot of English. What is the CCG's plan to solve this, and what plan is in place to work with community and charity organisations to help deliver services in a more inclusive way? Erica?
Yep, thank you, Jason. Thank you, Francis. Yeah, absolutely. I think nationally and locally, COVID threw a much greater spotlight on some of the challenges that BAME communities face and the risks associated with that. We are lucky in Hull because we have some really good relationships with our voluntary sector organisations, Humber All Nations Alliance included as one of our community champions. So we are lucky in that respect, and we do have a CCG Equalities Engagement Network where some of these conversations can be had, because again it's another example of we can't just do what we think, we need to listen and understand what's the best way to approach this and make this work for this particular community. We recognise that a lot of work's been done to support our BAME communities, and we have updated our organisation's equality and diversity objectives, and that work will be coming out in the coming months, and we'll be looking to you and others as our local partners to determine those specific actions. So we're not setting the actions, but we're working with you on the actions that will have the biggest impact for our BAME communities.
Thanks, Erica, and thank you, Francis.
Can I just pick up a point? Sorry, yeah. I don't know if I'm supposed to do that, but there you go. Yeah, I mean, we recognise this, and at the peak of COVID, what we wanted to do, actually we did, was to distribute through our newsletter twice a week to our GP practices. And one of the things that we included was advice and guidance with regards to COVID in many different languages, and it was provided to us by an organisation called Doctors of the World. And they've got it's a really fantastic service, and they've got a good website that's got lots and lots of resources on it. And so we use that to distribute this information in many different languages into the community. The other point I'd briefly mention is that we've started a process at the CCG where we're bidding to become the first CCG of sanctuary in the country. And that's really about migrants and asylum seekers. And it's about embedding within all our different organisations and knowledge, information and appreciation of the challenges with those communities. It's about us sharing what we do with them and with other CCGs, and it's about learning even more about the needs of our migrant and asylum seeker populations, making sure that we've got the services available to them, and also commissioning more if we need to. So we've just started that process. There isn't one at the present time, a CCG of sanctuary in the country, so we're hoping that we will be the first one by summer of next year. So again, it's just to try to demonstrate some of our commitment to it. Thanks, Jason.
Thank you, Dan, and thank you, Francis. And this is clearly something that a conversation that needs to be picked up away from this AGM. So moving on to the next question. It's from Beverly again, from Hull CVS. So it's quite a long one, so if I go through this one. I'll go through it slowly so we know what we're talking about. So we know that CCG works hard to back numerous community projects financially and through engagement, such as the highly supportive Champions Network. Given that VCS organisations really shone during COVID-19, and this type of support is never more needed, I would like to ask if there are any plans to reintroduce a small grants programme to extend this support. If so, would grants give an increased opportunity to VCS groups who sit between starting out and growing their success before going for larger grants or commissioning? So it's the small community-based activity, the great idea that makes the biggest difference. So, Erica, can I pass that on to you?
Yes, thank you, Jason, and thanks again, Beverly. There's a really important theme coming through here with some of these questions, which highlights the importance of the voluntary and community sector, and Beverly's quite right in terms of how those organisations shone in terms of their response to COVID-19. I think within the first sort of 24 hours of over 120 groups came together to provide that response for people who were shielding in Hull. So a big thank you out to everybody who was involved in that. And yes, absolutely, we have had small grants programmes in the past. We did roll that up into our social prescribing budget, and over the last 2 years we've issued, in terms of small grants, just over 1.3 million pounds. What we're looking at now is how well that's worked and what's the learning from that. Can we do that better? Can we do that differently? How can we make sure that we really are sort of working closely with our communities and as you say, making sure we're increasing the opportunity to voluntary and community sector groups to get involved and to test out some of their ideas and grow some of their successes. So yes, it's high on our agenda, Beverly, for this year and into next year.
Thanks, Erica, and thanks, Beverly. And so on to our final question. This is from Michelle Shenton from Hot Yoga. So Michelle says, I run a yoga, fitness, meditation and breathwork studio in Hull, and I'm very passionate about Hull and the health and well-being of the people who live here. I would like to know how organisations like mine can work together with the NHS to help alleviate the burden on NHS services. So, Dan?
Thanks, Michelle. Thank you for the question, and it gives me the opportunity to talk about a couple of things that we as individuals and also the CCG feels very passionate about. And I think one of those, not only about the health and the well-being of the people of Hull here, but physical activity and exercise. I think during lockdown and the peak of the pandemic in the spring, it was obvious that people were getting out and exercising more maybe than they'd done before. They were using it as an opportunity to get out, start walking, cycling, doing a bit of running. I've never seen as many people exercising. So it's good at the time, it's good in the future, and it's a good way of protecting oneself and preventing long-term chronic illnesses and protecting ourselves against things coming along like COVID, because there's no doubt that underlying health conditions, and that became apparent during the COVID crisis, put people at increased risk from severe complications from the condition. So as a CCG, we're one of the key partners in delivering the city's physical activity strategy, and we'll be launching a new campaign called Get Hull Active, which is around getting people walking, cycling, just spending time in the fresh air. And the other thing that happened was, obviously, since there was less traffic on the road, it was actually more pleasant to go out and exercise, whether that was walking, cycling or running or whatever, as we move forward. So, as an organisation, on behalf of the NHS generally and locally, we champion exercise. The second thing I want to talk about is a social prescribing service, which is possibly where an organisation like yours would fit in. Now, social prescribing is something that's been on the go for quite a few years, actually. And when you hear about things like saying it's exercise or cycling is available on prescription, or something, gym membership or going to the library or that sort of thing, what people are actually talking about is social prescribing, which isn't the prescribing of drugs or the use of other procedures in medicine, based on the fact that 80% of people's health is to do with what we call the social determinants. Erica talked about it earlier. So it's things like physical fitness, the environment that we live in, the exercise that we take, what we eat, where we live, the jobs that we have, all those sort of things which are impacted on by other parts of the services that we commission or our partners commission. So, and there's a real emphasis on this. So the social prescribing service is commissioned by ourselves and the local authority, and is seated within general practice and also the local authority. And it's so patients and service users coming into those services can access, whether it's fitness, meditation or other forms of help, through that process. And it's commissioned through an organisation called Connect Well. So a patient could come into a surgery, would see a social prescriber or a health trainer or whatever, and say, well, actually, have you thought about doing a yoga class? Maybe doing something like this may help, because we know that there is evidence that the things that you're talking about are beneficial to people, yoga, fitness, meditation, and particularly breathing work, because as a CCG we've sponsored some research done at the university around breathlessness and the psychological effects on it and what can be done about it. So I think what we need to do maybe is to really, outside the meeting, is maybe look at your service and see if it already fits in with social prescribing, and see how we can actually just boost the offer that we make to patients through that service. Is there anything you wanted to add to that, Erica?
No, I think it sort of fits with the earlier question as well. It is about looking broader than the traditional commissioning, and that, yeah, absolutely, we can pick that up.
Yeah, thank you, Michelle.
Thank you, and thanks, Michelle. And that's the last of our questions. So for those of you who may have posed questions during the course of this AGM and done that online, we will be responding to those online in the next few days. So we will publish the questions, the answers on the website. We will also publish tomorrow the questions that have been posed prior to this AGM and the answers that have kind of been given today. So just the contact details. If you've got any further questions for today's event, please email hullccg.contactus@nhs.net, and we will publish the questions and the answers to the questions we've dealt with this evening tomorrow, but the others will follow afterwards. And thank you for that. So over to you, Dan.
Thank you. Tomorrow. That's quite a deadline, actually, isn't it?
That's what it says on the slide.
That's
so
what
I'm
it
reading
says
the
on the
slide.
We'll do our very best. Thank you, Jason, and thank you for your hosting of the question and answer session. I hope you found it useful. It's not the way we would normally do it, because we would take other questions from the audience and it would be more interactive. But we are where we are. I hope you've enjoyed the AGM. It's been delivered in a different way than it would be done normally. At this point, I would normally wish you a safe journey home, but you probably won't have very far to go. But I'd like to also thank our team here, Sue, Emma, Ellie and Jason again for organising and officiating at the meeting, for Erica and Emma for their contributions, not just tonight but throughout the whole year, and everybody that works at the CCG. Again, my heartfelt thanks to you for your dedication, hard work, innovation, enthusiasm and good humour. I'd like to thank the guys here at One Point for putting on the technology, for making it go smoothly as possible. And I'd finally like to thank you all for joining us for this. And we'll see, hopefully, we'll see each other again safely when we're on the other side of the COVID crisis, whenever that is. But please look after yourselves. Be sensible, reasonable, responsible and courteous. Comply with the advice and keep everybody as safe as you can. And I wish you all a very good evening. Thank you.